little to no mobility. It's how do I maximize the next 100 years if I have the privilege of living that long? And so again, just shifting to this whole health span optimization. And so in 2013, landmark publication of the hallmarks of aging and identifying the hallmarks of aging. And then recently, the hallmarks of aging has been updated and has evolved. And so a lot of what we're doing in identifying and translating is breakthrough research that's harnessing one or more of these hallmarks at all times. So we're going to kind of go a little bit deeper into this as a nice overview and foundation, and then we'll get into the weeds together. And so this was presented 2 years ago now at A4M in Las Vegas. And this was a real aha moment for me, where we started seeing that we're only as young as our immune system. We're only as young as our blood vessels, right? There's so many things happening, even on a microvascular level, that we need to be mindful of and identify ways to naturally harness and evolve. And so a lot of, I would say, emerging literature happening is around senescence and ways we could support cellular senescence, immunosenescence, these cells that don't apoptose and, also coined zombie cells. So we're going to talk about some ways to help support and manage this at a greater level. And then we look at all the hallmarks of aging and this influence of inflammaging, right? This inflammation that goes unresolved and this low-grade inflammation that accelerates not only aging, but chronic disease development. And so again, just tying this back into hallmarks of aging and health span optimization. And then here we're looking at just a full body view of how we could modify and modulate naturally with peptides and nutritional supplements. So a lot to go over. And as Dr. Narl said, it's going to be tough to fit an hour, but I will do my best. And so I think a big change has happened over the last couple of years on the opportunity of oral peptides. I think when the craze was happening a few years back with the injectable peptides and all these 503As popping up, the common belief was that a peptide had to be injected for it to be meaningful in the body. And so we're going to go over some breakthrough technology that is disrupting this, as well as leveraging fragments of peptides, AI discovery that's leveraging peptides naturally occurring in nature, and also leveraging that into human studies to confirm that there are plenty of peptides that can be orally delivered that will enhance your current protocols. So if, again, not knowing everybody on here, you're just kind of a peptide 101 from amino acids to then peptides when they're 40 amino acids or less to then a full protein. And looking at natural peptides, bioidentical peptides to even synthetic peptides. So I think now, if you haven't jumped into the peptide world, hopefully after tonight, you'll have some thinking to do and some great opportunities that you can bring in that don't require a prescription, that you can buy in bulk and resell in your practice if you choose to do that. And so I think a lot of us already have a good foundation on hormones, right? Bioidentical hormones, where peptides fit in to the toolbox. I felt that a great place to start would be one of the most popular, one of the most well-known, one of the favorites, and that's going to be BPC 157. And so I also, and we'll share the slides. It's just a nice summary of the benefits of oral peptides, right? Enhanced convenience, improved bioavailability at times, reduced risk of side effects, and patient compliance, right? As far as availability, as a major point as we head into 2024 in the middle of this year, with just more and more 503As not offering all the peptides they used to for a variety of reasons we won't get into. And the explosion of research peptides that you may or may not be wanting. This is just another option. And so we look at BPC 157, even when this was a 503A compound, oral, injectable, topical, these were all deliveries. And so we look here, this is isolated from human gastric juice back in 1993. Incredible literature stemming from Croatia. There's well over 100 articles on PubMed as of today. Unfortunately, mostly animal studies. But if we look at the only human study to date by Dr. Edwin Lee, he has put his stamp behind our peptides we brought to market that he's using in combination within his practice. And so I wanted to go through and siphon through PubMed, and I handpicked 4 different studies identifying how BPC is working systemically. I look here at musculoskeletal soft tissue healing. We look at vascular repair, gut-brain axis, and even tendon, ligament, muscle, and bone healing. So a really wide range. The next couple slides, we'll go over that a little bit deeper about the beauty of BPC 157. And so we'll also talk about different forms of BPC 157. If you are using or considering using injectable, you'll want the acetate form. Arginate is the form that we are utilizing for oral delivery of BPC 157. This has a greater half-life and greater stability, one taken orally to ensure it's getting to where it needs to go. But here's just a summary. We look at immune modulating. This is a peptide that fits so many providers' protocols. The beauty of BPC 157, it doesn't need to be used long-term. The safety profile is there to be really used to do a lot of heavy lifting to facilitate repair, regeneration, natural healing, and then to reassess and reinvest your patient's money elsewhere after this is done, the heavy lifting. And so it was Dr. Kathleen O'Neill Smith that kind of gave me this coin of BPC 157 as the Swiss Army knife of peptides. And when you look deeper about how so many providers are using this, it made a lot of sense to me. And I thanked her for this analogy, and I've been using it ever since. But just a really nice summary. I think when we look at what the low-hanging fruit of utilizing this peptide would be anybody on a PPI, but then we look at a deeper role about the potential with IBD, IBS, Crohn's, colitis, ulcers, and then looking at even outside the gut, when we look at repair of the joints, or we've even had a lot of people call us about its torn Achilles or pre and post surgery, feeling that this was the difference maker in the recovery journey. And again, just kind of going over a few different ways of identifying common uses of this particular peptide. It's 15 amino acids, one of the larger ones orally, but we have a high degree of confidence about the arginate salt BPC being done orally and making a dramatic difference. A great place to start would be any gut dysfunction, right? So I kind of wanted to highlight a few different views of how this would layer in. And so whether you're doing probiotics, glutamine, zinc carnosine, we could talk all night about all different natural ways of supporting tight junctions and intestinal permeability. This is right up there for many providers of what they're turning to, especially early on in a patient's journey. So looking here with additional synergies, and we're going to talk about thymosin beta-4 frag. We're going to talk about KPV and some additional non-peptides that are utilized and stacked in with BPC to enhance its utilization and effectiveness with your patients. I always like to include a C of A if you have or haven't seen one on oral BPC, identifying the sequence. Another unique here is identifying the arginate content to ensure that it is arginate salt BPC 157. Thought it was a good time to highlight this if this is the first time you're seeing some of the behind the scenes quality control that's taking place. A big separator for us, at least, is the utilization of a bioavailability enhancer called SNAC, which is short for saccharose sodium. I was first introduced to this compound back in 2016 through a company that was using saccharose sodium bound with B12, and it was an oral B12 that had data showing it was as effective, or in some cases more effective, than sub-Q injecting B12, which for many that don't want to inject was a big deal. And so I started looking deeper at the role and potential of saccharose sodium, and at the time, no one's used this in combination with BPC 157. We are actually the first organization in North America to utilize it. You're also seeing things like oral semaglutide bound by high-dose SNAC. And so originally SNAC was there to make historically injectable peptides to give them an opportunity to be orally used and absorbed. Pharmaceutical use of saccharosate sodium is usually 300 to 500 milligrams because what it's doing at that dose is forcing it through the tight junctions and creating short-term intestinal permeability. What we're doing on a supplement standpoint is using a fraction of that dose, 3 milligrams, and it's creating more of a liposome protection around the peptide to withstand changes of pH to allow it to get to where it's desired to go. And so we have several formulations now we brought to market utilizing saccharosate sodium. So wanted to kind of highlight this. It has received FDA GRAS approval. That is what allows it to not only be used in the pharmaceutical world, but allows it to be used in supplements. Here's just one of the safety studies showing far higher doses and maintaining great safety and actually concluding that this is going to be a new trend where you're going to see a lot. And you're starting to see this even on a drug standpoint of some of the pharmaceutical companies turning to saccharosate sodium to turn what once was injectable only now as an oral opportunity. So if this is the first time this has been on your radar, definitely dig into this further, check it out, and see if it's something you want to see other ingredients be paired with. So another popular combination with BPC 157 is KPV, lysine, proline, and valine. This is a peptide that for many, it's incredible for mast cell dysfunction, pain, and gut inflammation and dysfunction. And so we had a lot of providers that were going through 503As when this was being offered and getting this compounded together with BPC, and we'll go over dosing, came to us and just said, can we make this, A, make it, but B, make it more affordable? And this is what we're always trying to do to allow it to get into more people's hands to make the difference that it needs to. And so KPV is a peptide that's also coined the antimicrobial peptide. Pretty incredible. You might have also used some of the metallic, the MSH, alpha MSH is what it's derived on. And what we're seeing is that the fragment here, the KPV, which is a tripeptide, has oral bioavailability. So you could have, or you may be using KPV 3 different ways: injectable, oral, and also topical. And it does wonders as a topical if you're able to get it for any of the inflammation on a skin level. How we're using it here is, again, any gut dysfunction. So ulcerative colitis is a study here that we're highlighting where KPV paired with hyaluronic acid as a nanoparticle made a tremendous difference. Therapeutic uses outside of the gut: wound healing, asthma, immune mediated arthritis. And again, you'll see here the eczema if you have a way to get it as a topical. What we're also doing with some of our peptides is adding in micronized PEA. I know this is not a peptide, but PEA as a lipid-resolving mediator is far more popular in Europe and Australia. It's starting to gain some momentum here in the States. Our bodies naturally produce it in height of inflammation and pain. By putting it in with the supplement, you're augmenting the production and helping the body better respond. And so what we've noticed, and when you have these small inputs of peptides, right, in the micrograms, there's still a lot of space in the capsule. So you can either use a filler that people don't want in there at a high level, or in this case, the micronized PEA is our functional filler. And so helping this layer in with the peptides, it works quicker. And so many of our providers are sharing that the PEA paired with KPV or BPC 157, patients feel it sooner, and it improves compliance with the peptide to allow that to do what it's doing in the back end. So for mechanisms of action, indications, you'll see here why we have paired it in several formulas and why it's gaining the momentum it is in the US. Really exciting ingredient that if you haven't used, hopefully you will use it. In terms of dosing, I wanted to kind of spend some time here. And the arginate salt BPC 157, 500 micrograms once to twice a day away from food is where we're seeing it shine. Micronized PEA at 500 milligrams is a good dose, once to twice a day. And the KPV also at 500 micrograms. Also confirming the saccharosate sodium at 3 milligrams. Again, if you see, or if you have a patient with leaky gut, and some of those pharmaceutical options that are in the 3 to 500 milligrams might throw some fuel on the fire, where we're at a safe ratio to do what it's intended to do here with the oral delivery of peptides. From there, I wanted to dive into a little bit of the thymic peptides. This is going to be thymosin beta 4 fragment. It's going to be the 1 through 4 frag. And we're also going to talk about a bioregulator dipeptide called Thymogen. And so here we're seeing peptides declining with age. And as you're seeing thymic peptide activity decrease, you're also seeing the risk and opportunity of chronic disease also increasing. Thymosin beta 4 as a very popular peptide, 43 amino acids. So it's now, after the repositioning by the FDA, was one of the reasons why it was discontinued by many, because it's over the 40 minimum. But the 1 through 4 frag, which we have isolated here as a fragment, is the workhorse responsible for much of the success and influence that BPC-157, I'm sorry, that thymosin beta 4 is having. The other beauty here, because you'll see some potential, you might read about the 17 through 23 fragment within the thymosin beta 4 causing some immune issues, specifically mast cell issues. So by removing that and focusing on the 1 through 4 frag, you're reducing any of those issues and giving something that is now orally absorbed. So what really caught my eye here with the 1 through 4 frag, why we selected it, was what you're seeing here with the modulation from things that it's reducing, things that it's increasing. And as we were getting out of COVID and just seeing a lot of the dysfunction that many patients were presenting, the 1 through 4 frag in an immune resilience standpoint made a lot of sense to bring to market, specifically in the synergy that we are. So the 1 through 4 frag here, in a bigger standpoint, you're just seeing a wide range. And so from organ support to even repair and regeneration, healing of the joint, muscle, tendon, ligament, and then even supporting apoptosis or anti-apoptosis. The second piece here is why we are seeing a strong positioning here and getting really in with the immune-compromised individual. This is one of Cavestein's bioregulators. It was a prescription over in Russia. It's now off patent. We have isolated these 2 amino acids and really saw its ability to strengthen a damaged and weakened immune system. And so if you haven't read any of Dr. Cavestein's work around the bioregulators, this is one of his more well-known books, great place to start. But looking at not only, getting back to that earlier slide where we talked about the immune system being so interconnected to health span and lifespan, but then also confirming that thymogen is also a geroprotector. And so looking at doses here, what we're translating is the TB4 frag 1 through 4 at 500 micrograms, thymogen at 500 micrograms, which is a significant dose in an oral standpoint, both at 500 micrograms. And again, you're seeing the sacroprosate sodium at the low dose to improve and enhance bioavailability of these peptides. I thought now was a good time to kind of get us out of our comfort zone, because many of you may already have known those peptides, but really go over the next frontier, right? Especially with so many of the changes happening on the 503A level, is what does the future of peptides look like? And I read about a company over in Ireland 3 years ago, and it was one of those things where, you read some certain things and you just kind of get the chills. This is what happened when I read about what this group in Ireland was doing. They've developed the first artificial intelligence platform that is cataloging peptides naturally occurring in nature. And so they've coined this the magnifier. And as of today, they have cataloged over 8 million peptides naturally occurring in nature. It's remarkable. It's a whole team of PhDs, scientists, mathematicians, and the timing couldn't have been better, right? Even when they started this, they didn't predict what was happening in the US. But what this is allowing to do, and it's not relying everything on AI, but it's leveraging AI to facilitate guidance. And so, for example, looking at muscle loss as a target. they're able then to use their catalog and go from 8 million to perhaps in this case 1,500 peptides that could be beneficial for muscle loss. Then from there, they're able to exclude peptides that would not be orally viable to give to humans that may knock off X amount. And they're able to then look at next steps to validate and scale up to eventual human publication, human clinical study. And so this group we have launched 2 peptides with, more to come, but really, really exciting about what they're doing and how they're doing it. And just thought this group especially would find this refreshing. And so the first peptide discovery that now has 3 human published studies behind it is hydrolysized from the fava bean, believe it or not. It's multiple peptides that are being isolated out and then dosed correctly to make a difference. And we're going to talk about how it's doing it. We have identified the dose, and what it's really doing is it's activating muscle protein synthesis. It's reducing muscle breakdown, reducing or minimizing inflammation induced by exercise. And they did head-to-head studies with the gold standard, which was peptides derived from milk. And what we're seeing here is really some major patient groups that can stand to benefit from this. Sarcopenic patients is a major area. Immune-related muscle loss is the next. Potential GLP-1 muscle issues, statin-induced muscle issues, hormonal issues associated with aging, to even your weekend warrior to professional athletes. So I've had doctors taking this personally, randomly took this, went on a ski trip and said, Michael, I had no business being on this peptide and skiing every single day with no breaks, no aches, where in the past I would have been, laid up at night. And so we're seeing fast activity, but as you know, in measuring, it takes time to actually rebuild muscle. And we'll go over some of the literature and what it's doing and how it's doing, right? We're seeing here slow burst, fast twitch muscle. We're seeing modulation of inflammatory markers, modulation of even NAD plus and sirtuins. And the latest study, which let's see if I don't have it, I'll get to the latest. We'll kind of go over these 2 here. And so looking at its comparison to milk-based peptides, reducing fatigue, increasing muscle protein synthesis. And now the latest study was over 57 days, confirming the average participant had a 1% increase in bone density. And so looking at, again, this peptide derived from fava beans at 2.4 milligrams, really doing some incredible things in our body. From there, I wanted to go to another newer peptide, and this is a fermented peptide. We're kind of switching gears now from muscle and bone density to satiety and hunger cues. This is a major area. We're seeing now literature originally at 8 out of every 10 patients, seeing it more like maybe 9 out of every 10 patients that are metabolically not where they need to be, right? So glucose disposal issues, insulin resistance, having issues beiging the tricky white fat, mitochondrial dysfunction. So looking at a peptide that doesn't need to be injected is very favorable for many, either as a first line of therapy or as a phase 2 after a GLP-1. So this particular peptide, fermented from Saccharomyces cerevisiae, has some really incredible human data behind it. We'll go over it, especially at 500 milligrams. So mechanism of action short term is looking at regulation of ghrelin, but longer term, as you take this, the more effective it is, and you're seeing modulation of ghrelin. So 2 really unique things, especially when used with other natural therapies, could create a really nice stack that casts a wide net in the body to identify and support a lot of the underlying issues that are causing the metabolic dysfunction. So here's a study that really caught my attention. 500 milligrams over 8 weeks. The average participant, this is over 100 patients in this study, so a nice data set. Average patient consumed 600 less calories a day, which is really remarkable, especially when you're not using this as the only solution. And so in summary, again, identifying the right dose, right time of day, identifying the right expectations with your patients about how long to stay on it. And again, just an overview on some of the clinical outcomes with the references. And so if you haven't utilized this particular peptide, obviously it is orally stable and viable, and hopefully will complement a lot of your current protocols with metabolic dysfunction present. So in stopping here, we went over BPC 157, KPV, thymosin beta 4 frag, the 1 through 4, thymogen, peptides derived from fava beans, and then we also had a satiety ghrelin leptin peptide. All of these as orally bioavailable peptides you can utilize in your practice. Did you want me to pause now for any questions as it pertains to the first part of the presentation, or continue with the second part?
It's really up to you. Are these, especially the last two that you presented, are these available, or are they sort of experimental, or are you working on them?
Everything I've gone over so far is available now.
Okay.
And available now, like not as a new product that we're launching tonight. All of these have been launched with over 12 plus months in clinicians' practices with great success.
Okay, great.
I just wanted to jump in there, if it's okay, just to make a comment. First of all, I appreciate the amount of study, translating the literature, really going deep with this stuff, because I don't know what your degree is, but a lot of times, people who are on the more of the entrepreneurial end of things, they seem to graze the surface, and you've definitely done the work. And I think this is the future. I can see it already. And if it's coming from these natural sources, all these different targeted peptides, I could definitely see the value in how this would help. It's almost like the next level supplement, I guess, and that's all I wanted to say. I think it's really awesome.
No, thank you. I really appreciate that. It was hard to identify the ingredients to talk about tonight, because we're really bringing a lot to market. This is a full-time job for us. We really care about patient therapy, patient outcomes, and putting together formulas that put the outcome first. So some other peptides that are available now we didn't have time to talk about are ACE inhibiting peptides derived from lentil. That is available now. That's also through the AI discovery. We also have buckwheat derived peptides for immune dysfunction. That's available now. Two peptides that are undergoing clinical studies right now in Australia, not available yet, but hopefully by the end of the year, will be a glucose control peptide. And the other one will be a cortisol peptide to support sleep and stress. So those are not available yet, but are undergoing human clinical studies as we speak.
Okay.
And so the next part I wanted to shift, I'm sorry, go ahead.
There's some questions in the chat. Do you want to do them now, or do you want to continue and do them all at the end? It's really up to you.
However, this is your group. I'm ready for anything you want.
We usually do it at the end. So
all right, so we'll wait.
Go ahead.
So I wanted to now identify, there's a lot of ingredients to pick from within the portfolio, but I wanted to highlight a handful that I think you all might enjoy. Perhaps maybe the first person within the 4 years of this group to talk about. Maybe not, but we'll dive in. And so I wanted to kind of go over a really major area I was tasked to support. And this is the amount of fatigue that you all are seeing on a daily basis. And how many people that you see are either a slow or fast metabolizer of caffeine, genetically don't do well with caffeine, but yet how many people are turning to caffeinated beverages, these energy drinks, chugging coffee all day, but yet they come to you and they say, Doc, I don't wake up refreshed. I crash in the afternoon. I have constant brain fog. Help. And so there is a brand new ingredient that we brought to the health practitioner market back in 2023 that's called paraxanthine. And we're the only healthcare practitioner brand with it still. So I wanted to talk about it this has been such a game changer for so many patients. It's not the sexiest on paper, but when you think about a patient that doesn't have the motivation, energy, or bandwidth to leave the couch and move, right? Whether it's walking or getting to the gym or doing something, the whole protocol is at risk. And so I wanted to start with this as we get to the second part, which are non-peptides, but really emerging innovation, and identify paraxanthine. Paraxanthine is the majority of caffeine converts into paraxanthine, but as we said earlier, if you're a slow metabolizer, a fast metabolizer, just don't do well with caffeine, you're not getting it. Or some of these other metabolites could cause some dysfunction and not getting the outcome we want. So we're going to talk about paraxanthine here. An incredible group of researchers that we're partnering with and licensing with are they filed and been awarded over 20 patents so far. A lot of data is emerging in the near future with the group here. But looking at this as caffeine evolved, and we're going to kind of go over what that is and what it's doing. And so a clean stimulation. So the nice thing about paraxanthine, it's a 3.5-hour half-life. You get all the benefits without the crash, without the jitters, and you don't build tolerance. And so the nice thing with this, if you're dealing with someone that's having issues in the morning, you could take this. If you're crashing in the afternoon, you could still take paraxanthine without it disrupting sleep. And I think that's a really major issue. A lot of people turn to caffeine for weight loss. You're getting still those same benefits with paraxanthine. And so just really excited about not only delivering this, but delivering this with other synergistic advancements to put our brains in a better position to focus and thrive naturally. And the more you take paraxanthine, the more effective it is. So really, really unique. Here's a nice summary of what the literature, and you'll see the literature's very recent and continuing to evolve. But you can use this even as a pre-workout, coffee or caffeine replacement, energy drink replacement. We have people doing it for hangovers in the morning. You have a presentation coming, you could take this. And we dose the paraxanthine within 2 capsules to allow dosing titration. So you're going to see studies with paraxanthine ranging from 1 to 300 milligrams as far as dosing. Per 2 capsules, the ideal dose would be 300 milligrams. And so paraxanthine, again, ADD, ADHD, fatigue. If this isn't within your toolbox, perhaps after hearing about it tonight, again, this is brand new in the health practitioner world, and we're trying to do our part with raising awareness and giving your patients other options that are needing it. The beauty about this also, it works on the first dose. So if you haven't tried it yet, let me know. So from there, the second ingredient I'm really excited about is L-BEBA. And so if you haven't heard about L-BEBA, we produce L-BEBA only during high-intense workouts. It's a metabolite of L-valine, and it's coined an exercise mimic or an exercise mimetic. And so we've identified a process to synthesize supplemental L-BEBA that you can take on days you don't work out, or take it on days where there is exercise to help the body augment and increase its production. But the more I dug into the data around L-BEBA, and even as of today, we're still the only health practitioner company that has brought this to your medical practice. But it is incredible at beiging white fat. So looking at it in a stack with metabolic, inducing issues, we just went over the satiety peptide, right? It would make a lot of sense with that. Also, another ingredient that we won't have time to go over with tonight, that's another favorite of mine, is dihydroberberine. But I'll leave it at that. But there's some incredible complements to be stacked with L-BEBA for all these reasons we talked about. So real exercise mimetic, there is only one group that has found the IP to synthesize and ferment the L-BEBA. This is a very rare amino acid. insulin resistance or insulin sensitivity with patients. We look at exercise and then getting it back to skeletal muscle. Next up, spermidine, another one of my favorites. And so looking at spermidine as an ingredient that you can get from things like wheat germ, we were looking at non-wheat germ derived spermidine. And there's a variety of reasons for it. And we were the first in North America to, I would say, go all in on therapeutic dosing. So we were the first to be at 10 milligrams of spermidine, non-wheat germ derived spermidine, to avoid any gluten issues. We are using a synthetic pure 99.9% pure DNA matching spermidine, and this allows not only the gluten issue to be avoided, but the ability to add a lot more additional ingredients inside that capsule. And so we have 3 different formulations with spermidine, ranging from 3 milligrams up to 10 milligrams for a variety of reasons. But this next slide was really what caught my attention, and this was Nature 2022 December. I'll never forget when this came out as a landmark study. It wasn't anything new. We were already really excited about the role spermidine was having, right, with inducing autophagy, its ability to support mitochondrial dysfunction. A lot of the N of 1 stories that were coming in for the beauty from within with hair, skin, and nails. But this study here, bringing it back to the backbone of longevity, and that's identifying spermidine's role in a variety of the major hallmarks of aging. And so this is hopefully, if you haven't seen this study, the references are here. I urge you to dive deep to the specifics of this, but looking at some major takeaways that are essential to any Healthspan optimized protocol. Next up, and we were talking about this earlier about senescence, and you're seeing a nice spike in literature on senescence, right? The landmark study with dasatinib and quercetin, and really looking at ways to induce and support, drop a hammer in the body, but then put the body in a position to do something with it. So you'll see a few other companies out there with senolytic vitamins, but that are proposing low dose senolytic activity as a daily drip. Our view, and the view with a lot of the literature on the drug discovery side, is high dose, short term, and allow the body to respond. And so one of the most well known in literature as a natural senolytic is fisetin. So I do want to spend a little time on fisetin and its ability, obviously most prevalent in things like strawberries and red onions, but hard to get the dosing that's necessary. But here's that landmark study identifying fisetin as a senotherapeutic. You'll see some usual supportive casts that were part of this study, and then looking at fisetin outperforming all of them. And so I think on the supplement side, we feel that the majority of companies are underdosing fisetin. We are delivering fisetin in a dose of 1 gram per serving. And so you'll see here, especially with brain health, and some of our practices that are doing our natural senolytic that features the 1 gram of fisetin and other cofactors are using this 3 servings back in a row. So 1 serving a day for 3 days in a row, and then 2 days off, and then repeating for a few turns. And what we're seeing is that some of those tricky immune cases, patients that may not respond to certain biologics or steroids, histamine issues, flare-ups, autoimmune conditions, this is revitalizing and repairing a damaged immune system to put it in a better position to have the other therapies to thrive. So short-term, high-dose fisetin has been very favorable, and I wanted to highlight it here as just as, you know, with enough time to highlight a handful of standout ingredients on a natural side. From there, I wanted to talk about one of the next exciting, incredible ingredients, ergothioneine. This is an ingredient most prevalent in mushrooms. And Dr. Bruce Ames right now is lobbying to have ergothioneine as the next vitamin. Not sure if it'd be vitamin L for longevity or something else, but this would mark the next vitamin added since vitamin B12 was many years ago. And so ergothioneine we have ergothioneine receptors in all our mitochondria, yet we make none of it. So we rely on outside sources. And there's been some major studies identifying hundreds of natural therapies and its impact for different disease states and lifespan and health span issues. And ergothioneine has been scoring at the height of all of that. And so ergothioneine is gaining major momentum in the longevity world. And sorry if other speakers over the last couple of years have spoke about it, but this is one we are stepping up in a major way with some updates to current formulas. We have this featured in 2 formulas at this point, at 10 milligrams and 15 milligrams. But the one that is 10 milligrams is going through a reformulation right now. It will be bumped up to 25 milligrams come September. So really exciting to see where this is going. There's been some incredible studies published recently that are putting a lot of eyes on this. And so we're seeing this here, not only for mitochondrial dysfunction, but really helping combat oxidative stress and then supporting inflammation, that viral load in a cellular level. So ergothioneine hopefully will also be on your radar and part of your toolbox. This is an interesting study here that the reference, it was looking at ergothioneine as a potential for treatment of COVID or long COVID. Don't want to go in the weeds there, but the reference is there if you wanted to look at why some of the researchers were pointing at ergothioneine as well for that. And then we just added it into our senolytic complex for its impact with healthy neuronal cell and senescent neuronal cell for age-related pathology. So, like I said, no short of publications pointing to ergothioneine to be, I think, the next big thing in longevity medicine. This comes up a lot too, because I have a lot of providers who are like, well, I'm using CoQ10, I'm using glutathione, I'm using vitamin C. So looking at how ergothioneine stacks up, some really standout takeaways on this slide is going to be the hour or the half-life, right? We're seeing the half-life of ergothioneine through the roof compared to oral glutathione, for example, antioxidant effectiveness rating, and even look at just the overall bioavailability. So this is one that hopefully was already on many of your radars, but if it wasn't, it is a good one. Next for this group, I wanted to talk about a pretty controversial topic, right? NAD precursors, right? It's like you got this one side talking about NR, another group talking about NMN. You have David Sinclair, who's been super controversial of late. And so looking at a way of a novel ingredient, we were actually first to market with this ingredient that's a blend of teacrine, cuprous niacin, and wasabi. And we brought this to market when it was unpublished studies. And now there's 3 human studies published on what this is doing. And this is why I wanted to spend some time talking about it with this group, because the beauty of this ingredient combination is that it's playing offense and defense inside the cell. And so what it's doing is it's actually identifying the root cause of why our bodies are depleting NAD, while putting the body in a better position to naturally create more NAD. And so really, really exciting. You can still pair this with the other usual precursors. Most notably, I'm on board with niacinamide as a more cost-effective precursor. There's been some new data on NMN with actually losing stability in a supplement over time very quickly. And so more and more as time has gone on, I'm on the niacinamide bandwagon with this precursor combination as a really nice way. And if you're doing injectable or IV NAD, this is not to replace that. This is the at-home in-between therapy to just make everything more effective and last longer for here. So, and here's an actual snapshot of the 3 human clinical studies. And so we're looking at the enhanced trial. We're looking at another study that was looking at some of the age-related epigenetic chronological age testing, and even now with some of the short-term effects with circulating stem cell activity. And so this is another really, really unique ingredient that is hard to find, that we brought to market with the IP holder a few years back, and continuing to evolve the synergies that are being paired with it. From there, I was going to just sneak peek some emerging innovation. It won't be those two peptides I spoke about earlier. This is going to be where I'm seeing a lot happening on a publication standpoint, but also in an IP and innovation standpoint, looking at things like glycoproteins and breast milk mimetics. And so right now, a huge area of interest, especially on the consumer side, is colostrum. And similar to the AI peptide finder that we highlighted earlier, there's another group out of Israel that has created the first AI software finder that is taking fragments of colostrum based on an intended target and then able to identify what's the right dose for human consumption for that intended target, and then to mimic a pattern of breast milk of the final ingredient formulation. And so what you're seeing here in the breakdown from immunoglobulins to glycoproteins and everything underneath it will actually be the label claim of the product that we will be bringing to North America in the fall. And so two of their materials, the colostrum fragments, one is designed for rebuilding gut dysfunction or damage from gut from the intestinal permeability, and the other is the muscle and repairing damage to the muscle. And we have put both of these fragments into one product. And so I'll leave it at that for now as a little teaser. But again, these are call outs that I've never seen before. Really excited to bring this to patient care. The second piece is an evolution of an oldie but goodie, right? We think about lactoferrin, and obviously lactoferrin for female health, looking at iron support, but there's a lot of focus for geroprotection with lactoferrin. And the only lactoferrin available to date is bovine-derived lactoferrin. And so we have partnered with another biotech startup that has created the first human identical lactoferrin. This will also be introduced to medical practices in the fall at some point in September. Very exciting opportunity here with the first ever human-derived lactoferrin. And now through their lab that's actually on Park Avenue in New York City with 35 scientists, food scientists, this is the first of many exciting IP innovation that they will be bringing to market in collaboration with myself. Also, adding to that will be the human milk oligosaccharides, and the most abundant HMO is 2FL. So we've added 2FL at a significant dose in with the human-derived lactoferrin, along with the postbiotic with over a dozen human clinical studies on it. So again, just giving you a sneak peek into the next frontier of innovation to optimize your patient's health span. We could break now for questions, and if you want, we could convert over to the non-CME portion.
Mike, do you want to answer questions?
Oh, just go into the chat.
Sorry about that. So
Yeah.
I was muted, so I was going to read you the questions. What laboratory do you use as a manufacturer for third-party analysis?
So there's several depending on the finished product. So there's not one we use, and we do several points of quality assurance. So raw material will get quarantined and identified for purity and potency. Then we do finished product testing, and that again it varies. There's actually more and more labs, it appears to be popping up, and so we're always vetting. If you all are familiar of any that you're using or have used that are trusted. We always like to do multiple points of the assay to confirm identity and stability of the peptide.
Question regarding BPC 157, what lab do you use?
What do you mean? What lab? Like who's synthesizing the peptide?
Who you presented a C of A? What
Yes.
was the lab?
Yeah, so that unfortunately is we consider a trade secret of who's synthesizing our peptides, but is the same vendor supplier that is supplying 503A pharmacies.
Will BPC 157 have an effect on the angiogenesis of cancer cells?
Yeah, this has been an area that I think causes a lot of controversy, right? It's a little bit unknown. It is part of the mechanism that it does. I have not heard much of this being a cause, but we have to at least talk about the potential of it happening. So we always say with active cancer to avoid its use, and specifically also the thymic peptide should also be avoided with active cancer.
Mike, to support that answer, actually, in relation to, I attended a SEEDS conference, Dr. SEEDS. Actually, they are using BPC in cancer patients, but cancer patients that are actually in remission. So you're right, active, I guess, cancers should be using it in caution. But it has been documented that it has been used in, I guess, remission cancers.
Yeah, thank you. Yeah, and I was at that lecture as well. I'm still not comfortable to be the one to say that, but I'm glad you brought that up. It was a very insightful presentation and somebody I'd like to actually bring on and talk through a little bit more about what they're doing and how they're doing it.
I think that BPC should be used as a primary peptide for cancer patients. There are other peptides which have a much better profile that should be used. BPC is used for many other reasons, but I would not use that for cancer patients unless the patient has a surgery and is recovering from surgery. That probably would help in healing. But at the same time, you can use the other peptides like thymosin A.
Go next. Okay. Somebody asked about KPV and tanning, and then there was an answer no. So I'm not sure with that. I know
Yeah,
melatonin, was it melatonin 2 causes tanning?
and one, I believe, as well. KPV would not have any of those issues. You know, similar to like a PT-141, right? That wouldn't also cause tanning, but similar, you know, amino acid sequence.
Okay. There's a
Yeah,
question.
it's melanotan. You're correct.
So a question about peptides for osteoporosis, and you did mention one of them, one of the newer ones that will improve bone density, right? The Peptistrong.
Yes, yeah. So, yeah, I mean, that is the trademark. That is the license name, Peptistrong, which we're featuring at the study. 2.4 grams would be the one with the bone density. And you know, I know we always go back to vitamins A, D, K. You know, some of those, the fat solubles. The high dose vitamin K2 is another one of my favorites for bone density as far as part of the protocol. And some people are also saying BPC 157 could also help strengthening bone, especially in a fractured state, and speed up the recovery there.
What do you call high dose vitamin K2?
Yeah, so this is not to get too off topic. This is an area of a passion for me because in the U.S. the label laws are very loose as it pertains to labeling vitamin K2, where in Europe you have to actually spell out how much cis versus trans you're using or the formula contains. In the US, you do not need to. So many companies to compete with Amazon are spiking high dose K2 derived from cis, just like with resveratrol, right? You list trans resveratrol. It's the trans that is bioactive in the body. That's what's doing the heavy lifting. We're doing 300 micrograms of a double microencapsulated all trans MK7, and that with the D3 and the A is really where you start supporting pathological calcification.
Thank you.
Is it possible for you to explain why trans works better?
Could you ask the question one more time?
Is it possible for you to explain why the trans form works better than the regular K2?
Yes. Well, I don't have those slides in this presentation, but if you do Google or check out, there are literature on the cis formation and what the transformation. The cis is not being absorbed in our bodies; it's foreign. The transform is what our body is using and is accustomed to. Think of it more like bioidentical K2. It's the transform. I would say, as a raw material standpoint, just give you underneath the hood, it is far more expensive, obviously, to use the all transform. And being in the US, since you don't need to claim it and declare it, many are not doing it. They're using a blend that's probably 10 to 20% trans K2, unfortunately.
So if you go, Dr. Patel, if you go to longevinex.com under articles and look up the article on resveratrol, you'll find everything you need to know about it. And it's written by somebody who's speaking to you right now, so I know all about that.
Isn't it the most of the
it has to do-
formations?
It has to do with the shape as trans versus the cis. The
Oh,
trans is
okay,
like a
I
circular
understand
shape.
that.
Yeah, sort of like the
Uh,
cyclodextran.
Isn't that the most of the formulas contain the trans form?
For resveratrol, yes, because the label laws have evolved that you have to declare trans MK7, trans resveratrol. For K2, that is not the case in the US. You just could generically say how much K2 you're using and not declare cis versus trans. We hope at one day it will be common where it's a level playing field and everyone's using trans K2 and it's just, part of every supplement fact label that you can find.
Hey,
So
Mike.
you mentioned about your formula for osteoporosis. So what dose would you use for osteopenia, and what dose would you use for osteoporosis?
Well, I don't know if I can go over names yet. We are, or can't.
Yeah,
I
why
think
don't
this
you
is still the CMA.
Yeah, just hold that till we're done here, okay? We'll get to it, Dr. Patel.
Okay,
Um,
thank you.
Can you comment on thymosa alpha 1 and melatonin 2, and do you have those in pill form?
So neither are absorbed orally. And so that would be obviously the first barrier that we have not found a solution for. I feel thymogen and the combination with TB4 frag 1 through 4 gives TA1 a run for its money on an oral standpoint because TA1 you can't get. There is, I think, one compounding pharmacy that is doing thymosin alpha 11, and that is brand new, and I don't know a lot about it. We did look at making a thymosin alpha 11 as potential oral, but could not get it absorbed orally, even with high dose snacks. So we went a different direction. But at this point, to answer the question that was originally asked, neither of those are an option orally at this point.
Hey, Michael. Lactoferrin and ivermectin. I'm part of a cancer group, ivermectin cancer group in Telegram. And ivermectin together with lactoferrin seems to be a powerful anti-cancer. Have you heard about that, or is your company working on that?
It is on our radar since the formula we teased is not out yet. We've been limited, but very excited and interested if we want to talk off the webinar about potentially doing something together and exploring what we're sitting on here. Because I think even once we launch that innovation, we truly don't know. Because there's even some benchmark data that they're showing that lactoferrin's great, but the average person isn't absorbing and maximizing bovine-derived lactoferrin the way it would be if it was human identical. So we're just beyond excited about the therapeutic potential that will be for many.
Amen. Amen.
What about the use of ivermectin in a higher dose for cancer patients? Like there was an article for 1 to 2 milligram per kilogram of body weight to be used? And if it is so, for how long would you use it? Now,
Was
Dr.
that-
Patel, I can probably help you with that. Because in the
Okay.
cancer center, we're using ivermectin also. And we dose this, yes, in accordance to what you just said. And we give our patients a month's dose of this. And then we will observe this patient through cancer markers. But most of the time, as we see it, again, we're looking at the safety of liver profiles and even kidney profiles. We're not seeing any movement on that end. So I think it can be declared safe through observation through these data that we have. But again, it's been done so many different ways. But that's our, I guess, way in the cancer center.
so are you giving it 1 milligram or 2 milligram per kilogram?
We're starting at the 1 milligram initially. And as we see them progress with it without any side effects, we go for the higher one, which is even 2.5 sometimes.
Okay, and in obese patient, would you use the lower dose or would you continue to use the same dose?
We usually go for the conservative measure. I mean, regardless of obesity or not, just because, of course, this is something that is basically out of label use. So the lower doses always will be the start point of everybody.
Are you using with the lactoferrin or you're not using with lactoferrin?
I have myself inserted that in some patients, but not all. Usually
Okay.
it's pure ivermectin. But
So
yeah.
what dose do you use for lactoferrin?
Actually, the ones who comply, for the reason that if you think about it, after our 3-week cancer therapy, they are already on so many supplements. So these
Right.
are patients that are already overloaded. So if somebody who just will say that, yeah, I'm okay to take another one, then they're the ones who probably will be a candidate. And again, the cost, it's so high of a cost already for the other supplements to take.
So the ivermectin, then you give it daily and on those dose for 30 days or
Daily,
you
yes.
give like 3 days a week
We do daily.
daily.
Mhm.
And how long have you noticed that the cancer markers becomes better or inoperable cases and things like that?
Yeah, that's a kind of like a tough question for the reason that these patients are also on other things. I only have 2 patients who are solely on ivermectin and lactoferrin, and so far one of them would be a prostate cancer patient, and the PSAs have been stable for almost 6-7 months now. The other one actually dropped off
Stable
because
at
of
a higher
cost.
level or normal level?
Normal level, not the higher one. Just because again, the price of ivermectin, they are compounded, and I'm not using the horse version or the cream. The other one dropped off for the reason of cost of ivermectin also. So I basically have one that I'm monitoring.
In this prostate cancer patient, did that patient remain only on ivermectin and you brought the PSA level to normal?
When I say stable, it's not normal. So the PSA right now is, I think, so it's a post-prostatectomy patient, and ideally it should be 0. He's staying at a 0.3, I think, on
Okay.
his PSAs. So
Okay.
it's pretty steady, but it's still there.
So he was not then the metastatic prostate cancer, was it?
No, the reason for
No,
that
okay.
is,
Yeah, so
I hate to break this up, but we have our guest here, so we can discuss this in a little. What about the mechanism of action for paraxanthine?
Yeah, so similar mechanism. I think I had that. Let me go back. It's similar pathway that's happening, right? Likely mechanism. So it's not truly confirmed, but a adenosine receptor antagonist would be likely mechanism of action of what they're seeing this is doing. So just a cleaner alternative, just in summary, back to some of the shortcomings of caffeine. And then obviously the biggest shortcoming was the tolerance buildup that many are having with caffeine that we're not seeing here with paraxanthine.
So is that a different, and not to get too deep into it, thank you, by the way. So it looks like it's still a similar mechanism as caffeine, but it looks like it's elevating dopamine and glutamate via antagonizing the adenosine one. Or is it like a longer acting coffee, or it's like a stronger version?
So
Again,
it's shorter acting. Caffeine lasts longer, but think this is more precise. So again, by skipping the body's ability or need to metabolize, right, or your slow or fast metabolizer of it, you're skipping that and you're getting the actual end result. So I'm trying to think of like a good analogy, right? It could be like you could drink a ton of green tea or just take EGCG, right? But what's your preference? You could drink a ton of red wine or do transverse resveratrol, as we spoke about earlier, right? So you're getting a caffeine fragment that it alleviates all the potential shortcomings.
No, I think that's a great analogy. And for somebody who's having difficulty, like you said, the fatigue factor, I could see how just getting something right to the receptors to flip them on, in the most natural way. I think I could see the value.
And fast acting, right? Again, we talked about the need for something like this to work ideally on the first dose, which this does. And so really sets the tone for a lot of other things that need to happen in the patient journey.
Thank you very much.
Absolutely.
Somebody asked about do you have any literature on dihydroberberine? Any info?
Yeah. So we were one of the first with dihydroberberine. I will give out the website at the end when the CME part is over.
Right.
Every formula has a breakdown of every ingredient included with every reference we've included there. So full transparency. The beauty of dihydroberberine, if you want, I could touch on it. So it is berberine in the body converts into dihydroberberine in the gut. This is what causes some of the gut dysfunction because high dose berberine, for some, they can't do it. So by giving the body ready form that it converts into, you're also getting 5 times the bioavailability because of that and double the half-life. So you're getting all the claims that berberine has, but you're able to use a lot less of it and make it more bioavailable.
Okay, we use it in our clinic in fairly high dose, along with the transverse resveratrol for our weight loss patients to help them keep the weight off, not necessarily lose weight, but we use it as an aftercare. And we've had pretty good success with that. One of the big complaints is we lose all this weight and then it comes right back. So we've been working on some strategies, and we've actually used the transverse resveratrol and transberberine or dihydroberberine also. So
Hey, Dr. Clearfield, could I add something really quick?
Sure.
I was going to say we actually have had success using berberine of all conditions with a patient with FSHD, muscular dystrophy. It actually turns off the gene that is overexpressed. Of all the things, berberine is the one. But the limiting factor was how much berberine he could tolerate, and I could see how this 5 times the bioavailability could be. But I wanted to put that out there so people could hear that, hey, berberine, it's in the literature, can be a frontline treatment for a certain kind of muscular dystrophy called FSHD. Thank you.
So,
And have you heard about milk thistle? Supposedly milk thistle helps with the absorption of berberine. So it's kind of been a big thing. Yeah.
Perfect. Thank you. I got it written down.
Yeah.
Any little thing.
So yeah,
Amen.
We use 1,600 milligrams a day, which is pretty good dose, with gynostemma, which is an AMPK activator also. So Next question. I thought breast milk was the main source of plasmalogen, a major component of oligosaccharides.
So
That's
plasmalogens are,
besides. Not plasmalogens or oligosaccharides.
You wrote it, Ken.
A major component besides
Oh, besides. Okay, sorry.
oligosaccharides.
I'm sorry. So what was the question?
The question that you were bringing up wasn't addressing what I thought was really important, which was plasmalogens.
Gotcha. Well, I was just highlighting what the technologies we're putting together, pairing with the lactoferrin. That's what I was honing in on, was the 2FL component of the human milk oligosaccharides, which is the most
You
abundant.
were trying to create something that would replace.
So, okay. So you're saying that the plasmalogens, in your view, would be
Critical.
critical. Yeah. Does not say that that still can't be part of the protocol. Absolutely. There's some tremendous work
I
behind
think that's
the
a
plasma
whole.
as the only part of the protocol.
I I only saw it for what, 10 seconds?
Oh, yeah. We were just going into some new things happening around the lactoferrin. That was the main
No, it's
takeaway.
all exciting. It's
Yep.
it just I had a question about it and it doesn't sound like it was part of the discussion.
No, we actually are trying to source new forms of plasmalogens. We are not close to one to market yet.
Can fisetin, can a patient take fisetin if they have allergies to strawberries, apples, grapes, and onions?
And that's an interesting question. I would say, is it a full-blown allergy? Is it more of a sensitivity? I mean, and I think also would be important is that the fisetin we are using is not derived from any of those. And so I would think, obviously under a provider's supervision, that would be something worth at least trying to see how the patient responds.
What are two favorites for rheumatoid arthritis?
On an ingredient level, I guess, since we're still covered by the CME, I do believe BPC 157 is one. The second one's is a hard one. I guess if I just wanted to keep it peptide only, I would say perhaps the BPC KPV combo with the PEA, that whole blend. Again, if you haven't dug into the PEA, I think it's an incredible molecule. We have another formula that we could talk about not when the CME part's over. That would be the 1-2 punch there on non-peptide ways of resolving low-grade inflammation.
Okay, we're getting close. You
Oh,
said
good.
KPV has mast cell stabilizing qualities?
It does.
Okay. All right, Dr. Neri, I think we have some online questions.
Yeah, so Mike, you kind of blasted my email. So you did a good job if you do that. So you have some questions here coming in. So one of the things that got in was actually snack. So when you mentioned about snack, it actually is like a new mode of carrier for the supplements that you were saying. Can this be used in conjunction with other supplements, medications, or you have to test it specifically to work together well?
Yeah, it's a good question. I would say you're going to start seeing it more frequently for things that historically were hard to absorb. I would say the biggest factor blocking more companies from using it is the price, which we don't use that as a barrier, but I think other companies with a lot more cooks in the kitchen and perhaps different intentions of why they have a company, putting profit first might be avoiding snack and looking at things like a bioprene black pepper, which I do not like using personally because it's blocking the cytochrome P450. And so we've been very happy clinically. We've had doctors, we're placing tens of thousands of bottles when it comes to SNAC, supported peptides. And it's not just a handful of incredible breakthroughs that we're hearing. It's pretty consistent. And so doctors that were using non-SNAC derived peptides like a BPC without SNAC start using ours, and they feel that it works quicker and lasts longer for what that's worth.
There's a question here that can SNAC lead to leaky gut? Can it affect the gut barrier as it goes through it? And as I think this was from the image that you popped up a while ago.
Yeah, so this is what I was talking about. So at pharmaceutical levels, which is 300 to 500 milligrams, that's how it's doing. It's forcing through the tight junction the compound. In comparison, we're using 3 milligrams. So instead of a force, it's more of like creating a liposome to more create that shield to withstand changes in pH, for example. Also, to layer on that, because we've had some people talk about this, we've had one practice in particular that has had a few hundred patients under care on our peptides that are doing very wide-ranging diagnostics, specifically intestinal permeability testing. And we've not had a single patient take a step back utilizing any of our peptides derived with low-dose SNAC.
Are they using what tests are they looking at for intestinal permeability? Is it occludin and zonulin?
Yeah. A lot of the Vibrant America tests or Vibrant Wellness, the zonulin, the wheat zoomer, they're doing Genova tests. I mean, this is one of the largest integrative practices in the country, doing a ton of diagnostics. It's a practice that we lean heavily on to get feedback of what we have or sometimes what we don't have and reformulate. So it's as a practitioner, Brand, it's always important to lean on you all on the front line to make us better and to make sure that we're positively influencing your protocols on a daily basis.
Right.
So you had a slide, KPV being comparable to fluconazole. So in the cases of vaginal candidiasis, we give only 1 dose of diflucan. Is this something that you see that KPV can actually compare to or even do?
That is going to be a question I don't have the answer to. And I don't want to just guess.
Sure.
I do know there's a topical option, and perhaps that's where the study was talking about. And if anyone has an answer prepared on this, please unmute and chime in.
But I think it's a good supportive therapy when you put that in there, because of course these women are suffering from that, and that's why that 1 dose really helps them a lot. But doing KPV, as you said, is not only going to deal with vaginal candidiasis, but mast cell stabilizers, right? So anti-inflammatory. So I think it's a good combination. Question here is difference between thymogen, thymosin alpha 1, thymulin.
Yeah, great question, by the way, this one. Thymulin and thymogen often can be referred to each other in some of the literature. And even some of the injectable versions of these can be found with similar names. Getting back to thymogen and the dipeptide that we're sourcing and why we're sourcing it, that's what we highlighted tonight. And then thymosin alpha 1 we don't have as an oral option.
Mitoburn, taken before exercise or after?
So ideally before, because then you're going to augment production of the L-beta during the workout. With how we're using it, which we really didn't get to yet, the L-beta is dosed at a significant dose of 500 milligrams. I did not talk about dosing on that. Usually it's 250 to 500. We're using L-beta in combination with dihydroberberine, with the satiety peptides, with a trademarked high-dose bitter melon, with grains of paradise, and then 2 AMPK activators, all in one synergistic stack.
Okay. You mentioned about types of peptides, bioidentical versus synthetic. So in the world of hormone therapy, we're a little cautious about using synthetic hormones. Is this applicable to what you just explained, bioidentical peptides versus synthetic peptides in terms of like maybe health benefits or risks?
Yeah, it was more of a slide just going over different deliveries. I will say some of the peptides we reviewed tonight would be considered synthetic peptides. You know, BPC, TB4, thymogen, KPV, and then nature-derived peptides would be the fava beans and the satiety peptides.
So
Question.
go ahead.
Okay, go ahead, Dr. Nario. But
Go ahead, Dr. Bruno. Go ahead.
Okay, are there any peptides that boost leptin?
The leptin peptide is what's called DNF10. And that's the peptides fermented from Saccharomyces cerevisiae with multiple human studies that we reviewed that short term is modulating ghrelin, long term will be modulating leptin, and definitely one to use in a variety of ways. It's got some really nice data behind it.
Would you have a catalog of all the, because today you covered a lot.
Yeah,
Yeah,
we're
once
products
we
and-
does, which
gonna get that
Oh,
shortly.
yeah, okay. We're not there yet. Okay, thank you.
How we doing,
Sure
Dr.
thing.
Three more here. Peel peptide stability. So we all know peptides very unstable, and now being mixed in these formulations with other supplements and also other components, this is stability maintained.
Yeah, stability really is only in question when we're talking about liquid solutions. So there's some sprays out there or sub-Q injections. That's where you're clicking the stability in keeping it in a powdered suspension with some of the lab testing we're doing, and then layered into how long we've had these out, so we're able to then test again. Some of our peptides have 2-3 years on them, and so there's no issues with what we're mixing and how we're mixing it.
Okay. KPV, as you mentioned, is basically alpha MSH. I think this is from a SIRS perspective. Can it increase actual MSH if it's low for somebody?
No, well, I should re-say that I haven't seen it, I haven't heard it. It's not to say it can never happen, but again, this is a fragment isolated out and then megadosed. We have not seen that happen with patients as of today.
You presented the magnifier. It sounds like it's the one that will dictate the peptides that will be coming in the future. So meaning peptide feature is so bright, it's not going to be taken over by bioregulators or I guess new stem cells or exosomes.
Well, I mean, if the question is what my view is and all that, I don't think it's replacing it. I think these are all supportive therapies, especially in combination. I think to have a partner that we have that has the magnifier, that's cataloging and investigating, and after they identified investing heavily in published studies with humans that we really haven't seen before with peptides in the supplement world, it gives us confidence of the path forward for peptides in the future. But we're still very high on exosomes and stem cells and PRP. I mean, I don't think it's one or the other. And I'm sure many of your practices are utilizing the best of all of these as it pertains to what's going to get the patient better the quickest and then maintain them.
All right. And lastly, I think this comes now from me because I know paraxanthine is something that you said that would actually be almost a replacement for caffeine, right? And you mentioned about the gene. Actually, it's the caffeine gene, as we call it. I'm pretty big about this because I have it. So 50% out there, as you showed in your statistics, will be affected by caffeine and will affect mostly in my patients and myself cardiovascular issues. So with paraxanthine being taken, and it's of course not caffeine, would it affect the slow metabolizers also, maybe even in the smallest or maybe an average way?
We have not seen that. That's what gives it so much promise of how many people that it could stand to help. This is part of the reason why we did a 2-capsule serving to even allow you to dose half for that patient population to give you dosing flexibility. But what we have seen, and like I said, we've placed thousands of bottles within practitioners' offices since we've launched it, has has been nothing but positive feedback. Like I said, it's not one of the more expensive formulas. It's not one of those real sexy, but to me, it's foundational.
Are you making those formulation under supplement, or you doing it under compounding pharmacy?
Everything we have reviewed tonight is under supplement status.
So you have a supplement manufacturer, injectable. What about the regulations about it?
Nothing we've talked about tonight are injectable. It's all oral delivery.
Are you using any delivery mechanism to protect those peptides from being digested and breaking down?
Yes, and that's what we spoke about with the saccharomycin sodium. That's the game changer, or what I call the secret sauce in our peptides.
What is the name of it?
Saccharomycin sodium, also known
it
as SNAC.
Is it polysaccharide?
It is not.
What is made from? Sugar? It's a carbohydrate. I mean, amino acid, fatty acid. What is it made from?
Let me get back.
And is it biodegradable?
Yeah, I mean it's being broken down in the body after it gets to where it needs to go.
Okay,
So,
so
hey, I don't know if you're seeing the slide. That I went back to the how we're improving and enhancing the absorption of oral peptides.
okay, so that's the structure. It seems like looks like bends and has a chain of carbons. It's a chemical, right? What about toxicity, or have you
Yeah,
any?
here we talk about the toxicity. So, I mean, you're seeing massive dose, 2 grams, 1 gram per kg in rats. I mean, this safety profile is super strong. We're using 3 milligrams, so no
It's
issue.
only oral and topical, or you don't do injectable, right?
We are not a pharmacy. Nothing injectable.
So only you do peptides, or you do other supplements?
We do a blend of different supplements in addition to oral peptides.
I got one more
Okay,
question, and then we can let you answer those. Are any peptides available elevated homocysteine that doesn't respond to B vitamins?
That's interesting. I would say, yeah, B vitamins are interesting. Homocysteine, more like you could look at the ACE inhibiting peptides that we have in our in a formula that we can mention shortly.
Mhm.
That could help there, with some other ingredients in there that would be working together to bring that down. If the B vitamins or trimethylglycine aren't doing the job.
Okay. All right, Michael, great talk. Lots of great information. We could have you on 4, 5, 6 weeks in a row and not cover everything. So I want to thank everybody for being here. And
I have one quick question, Dr. Clearfield.
we're gonna shut the video off, and then you can ask, okay?